wasn't feeling too good, he said. So we got to get a, what do I do the, how do I get the, how do I get this?
A rhythm.
The rhythm up here.
Rhythm.
I'll come over there. Somebody take over the camera, please.
So he's kind of feeling not too good. So even though he's 30, he's kind of short of breath, whatever. So give him a little oxygen breathe. Maybe just anxiety. He's got a couple of Versed on board. He shouldn't be having any problems. So we're gonna let him breathe some oxygen. Doing better? No, not really. Okay. So let's look over here. Full contact. No.
It's not plugged in.
Who was that? Who was that? All right, sir. Okay, 177. We should be okay. You're doing fine, sir. Whoa, okay, this doesn't sound right. Everybody see this? So, if you come to a really good lecture next Monday, it's going to be on arrhythmias.
Yep. On the 8th.
And so, things to think about, he's got plenty of time, he'll do well. 6 questions to ask every time you look at a rhythm strip. To kind of differentiate which way you want to go. Number 1, what is the rate? Because that's going to put us on which way we're going to go. Is it normal? It's going to be slow, it's going to be fast. Okay, what do we say here? Fast. And how fast is it? Too fast, right? Anything 140, 50 above is considered SVT. Okay, so we now got the fact it's fast. Number 2, what is it regular? What's the rhythm? Is it a regular rhythm? Remember looking at that?
March it out.
Yeah, it looks, I mean, just looking from the back, you can see it's not irregular like you would see maybe an AFib. So, okay, it's SVT, it's regular. Now, difference is, now the next question, is every P wave followed by a QRS complex? And we look at that and you can't see from the background. Yes, it is. All right, so we're good. So next question, is it a wide QRS complex? Again, we're getting a fork in the road, SVT or SV bad T, right? So it's narrow. So our diagnosis is SVT. The fifth question is it dangerous? And we can only see if it's dangerous is what he's doing. So we look at him, how are you doing? I'm doing very bad. I'm cold, clammy. I've got a pulse of 170, I've got a pressure of 70 over palpable. So now we got next question, do we treat it? Yeah.
Yes.
Okay. There are 3 things when you look at rhythm that you need to do. Number 1 is first of all, is there a pulse with this? If there's not, we go to PEA, right? If they're comfortable and fine with SVT, we do other maneuvers to drop that pulse down. If you're in between, they're not doing well, now it's time to treat. What's the first thing we think of? What we can do for this guy?
Pressure.
Well, not yet, not yet. So we still got pressure and we've got pulse and we've got SO2. It's not very good, it's 90. 2 things we can do. We got medication, we've got electricity. What's the first medication we want to give? Adenosine. How much we give?
6.
6 the first dose, okay. While we're drawing the adenosine, someone draws some adenosine, we get the pads ready. Because if the adenosine doesn't work, we don't want to take time getting the pads ready to shock him. We'll get them available while we are getting the drug drawn up. So first thing we'll do is, yes? Oh yeah. And we need some saline to follow the adenosine to make sure it gets in there and then degrade in the tubing on the way.
Pads are on, sir.
Anterior,
posterior.
Okay, very good.
It can only last for about 15 to 30 seconds.
Yeah.
Flush it a minute.
Yeah, flush
You
it.
want me to actually do it?
Yes.
So we'll take the time to draw that up. So, if the adenosine doesn't work, and we're still getting kind of, you know, we got the plug the machine in, et cetera, what do we do next?
Next dose.
And its next dose is how much? 12. Okay, very good. After that, do we give any more adenosine? No, because it's not going to work. If you got 2 shots at it and it doesn't work, we got to go something else. In an unstable patient, electricity. So she's drawn up the adenosine. She's going to give it, followed by a saline flush, 6 milligrams. Yeah. Intracardiac. No, can't do that. So. And you pour in the storm. So now the adenosine, the first dose, is on the way in. That's okay. Don't worry about it.
It's
in.
It's in.
needleless. You just hook
And
it.
flushed in. And we're going. Okay. Nothing's happened yet. Okay, let's get ready and get another dose of adenosine drawn up. We got the pads ready just in case. Now what do we see when you start hit the adenosine when it kicks in? Pause. An uncomfortable pause, right? You want to kick back in, start working again.
Is that what it'd be?
Oh, that'd be kind of like that. You're kind of going, yeah, I'm looking at somebody jump on. Oh, there we go. Thank God it came back. Okay, we're gonna get some more adenosine.
Wait a minute, what do we got here?
Oh, I thought we had done the shot.
Oh, we're gonna do that? Oh,
Yeah,
sorry.
Sorry.
So,
Tell
we'll
SVT.
go-
Back to- So, she's a couple of steps
Sorry.
We've
ahead.
had 12 milligrams of adenosine.
Okay, so, let's do more. Now we got shocking. Well, how do we shock it? Is it synchronized or unsynchronized? Synchronized, right, because you don't want to step on top of the T-wave. How much do you start with?
200 Jews?
Low. In a SVT that is neurocomplex, regular, 50 to 100, okay?
If we don't know the answer, remember the
Yeah,
red
oh, that,
button?
okay, now, so you think I know everything, well, I've only read the first page, right? I don't know the rest of this stuff. Every room has got this thing, and we learned the other day that even though the guy at the head of the table may have MD and have his ACLs done, he may not know the exact doses and timing, et cetera, to give. That is not a cheat sheet, it is a life-saving sheet, okay?
Right on.
We all can't be expected to remember all the doses. So if you do, it's great, but here's the guidelines. So, Caleb, what are we gonna shock this guy with?
5200 Jews.
All right, let's do it. 1,500 joules. We shock him. See what happens.
Shock.
Okay,
step
we're gonna
away.
Sync on.
Ready to step away?
You sync.
All clear?
Sync is on the button. Nope, right there, honey. There you go. When you see the dots, it's sync. Do your energy selection.
Down here.
Bring down
Now,
to
how much you want?
50.
50, okay.
Oh,
All right,
yeah.
now we're gonna charge it.
Charge.
And
And all clear,
Everyone
clear.
clear?
everybody clear.
Shot the red button.
red button.
So there you go.
Whoa, didn't work. Okay, so I still got the oxygen. Should have kept it on.
Yeah.
Next thing we'll do, we can bump up a little bit, right? We go to 100. So we'll try 100 joules and see what happens. So we're going to still be, he's
Ready?
still breathing
Ready?
spontaneously.
You have to resync it every time. Once it gets that shot, the sync comes
You got to
off.
go back and start at square one again.
Sync.
Okay.
That's it. Right?
Charge it.
Charge.
Charge.
Everybody clear?
Clear?
Stop.
Well, now you go.
Get wait.
Wait till it turns red. Now go. Hit it.
Okay.
Okay, now unfortunately the next rhythm that we shocked into,
Yes.
we're sort of thinking, hey, we're okay, and then we go,
So we go. Neural complex.
whoa!
Want to be ahead.
That's, okay, we have time, okay? What's the rate? Can't tell, it's too damn high, right? Too many squiggles. So, is it regular? No.
No.
Okay. Can you see a P before each QRS? No. Can you see a Y QRS? Probably not. Oh goodness, it's dangerous. You bet it is. Begin compression. It's time to call a code. So we hit the, somebody goes and calls the code
How do we
button.
call a code?
How do we do it?
Call charge nurse. Okay.
All right, we begin the chest compression. So we have somebody that's available for Caleb after he gets 2 minutes into it.
Yeah.
All right, anybody? Now, what do we want to do in regard to any medications?
Step stool for you.
We got an IV running. What's the first thing you want to give?
Epi.
How much?
One.
1 milligram. All right, 1 milligram coming on board.
So if you didn't know, it's right here, guys.
And how do we know if these are effective chest compressions?
Let's see the wave. You watch the wave.
And the monitor would tell you. We didn't hook it on.
Well, very good. Okay,
I
I've
can't
got
have,
two
the-
then.
I can't have
The real
both
life,
hooked up
we
at
have
the
to
same
take it
I
time.
know. Well, that's a good deal. That's great. I didn't realize they had the monitor like that. The other thing you can do is you can see if we got an end-tidal CO2. Okay? You want the end-tidal CO2 because I'm going to have a tube in my now. Above 20 or better. Okay? That means you've got good return of the blood from the periphery to the lungs to shoot out the CO2. Good idea there. So, you're given a milligram epi. What's the timing on the next dose?
And a slip sheet. 3 to 5 minutes.
3 minutes, okay. Now what can we give, or what should we give instead of epi for the next
She's
dose?
doing the defibrillator. Phyllis,
Vasopressin, how much?
What does it say?
What's the magic number? 2?
Concussions
4?
at
40.
40?
All right, so why do we give vasopressin?
We don't have to give anything else.
No, it does the same thing as epi, but because of the fact that someone a long time wrote it down in the codes, if a lawyer comes along, and this is what the guy's telling me,
Yeah.
lawyer comes along and sees that you've given 3 amps of epi and the patient died, well, why didn't you use vasopressin? It's written in here.
Huh.
So, it does the same thing. Increases the diastolic pressure. That means the pressure between beats. The coronary arteries get their blood flow during that time. So if you have an
How you
increased
doing,
afterload, it goes in that way better. So, vasopressin didn't work real well. Do it again. Anybody want to think about maybe shocking again? All right. So what are we shocking with? Is it synchronized or unsynchronized?
Synchronized.
Unsynchronized. Because there's nothing synchronized to it.
Everything
Aha, it's crazy. It's fixed. We can't see anything. So we're going to sit there and go to a unsynchronized shock. And how many joules? Can we start 50?
No.
Start at
2.
2. Let's go to 2. All right. Ready? Let's get ready to shock him.
Step
You
away.
got it. Keep on pressing. Well.
It's still charging.
All right.
Charge.
Everett, clear,
Go.
stop.
Go back to
All right. Now
compression.
immediately go to the next person who's coming to do chest compression. He's getting tired.
Okay, so
Just
Switch.
while we're doing this,
Yeah.
we want to start
It's all
thinking about the
about
causes. What's making this
Yeah.
patient
So
do this?
we got. So we're gonna get to the next rhythm soon. After we get that shock out of this, one more shot. We go 200 again.
No.
Keep going to the light.
300 is there. You go. Okay. Keep on going just so she gets charged up.
You gotta start it over.
Bypass it.
All right. Well, that's what we did. By faith, is ready?
Charge it.
Clear.
Everyone
Clear.
clear?
Charge.
Clear. Stop.
All right.
What?
Keep on pumping. Yeah, you bet. Now we'll get a new rhythm here in just a second.
Faster.
Lock your elbows.
100. Pop.
Okay. Oh, look at this. We have a return to spontaneous circulation.
All
Carol, is
right.
there a pulse over there?
Does it go
We
first?
feel pulse?
I feel, no.
No pulse. Okay. So what's it called then?
PEA.
Thank you. Okay, so what do we do now? Keep on doing what we're doing. Now we got to find why is this guy doing that. So you got the 5 H's and 5 T's. If you don't know them, they'll be in the book.
Right.
So, some H's.
Okay.
Thermia.
Hypothermia, hypovolemia, hypoxia. Then you got the H's for the various hypomagnesium.
Rate needs to increase
Kalemia.
at 100 per minute.
Hyperkalemia.
You go a little faster.
All right, so you got to sit there and think, any reason this guy's got any of that stuff going on, okay? Hypoxia, probably so. I mean, he's been not doing well. Hypovolemia, hadn't had surgery yet, so probably not going to be too low on volume. Hypothermia, it is cold in here, but not that bad. And then so we need to draw some labs.
So,
So we draw some labs on A-line that Caleb's already put in for us.
Right on.
And so, what are we going to draw for? We're going to check.
Gas.
Blood gas,
That's
okay.
right.
So what's that going to help us with?
Turn on what
10-6.
oxygen he's got in his
Yep.
blood.
CO2, oxygen.
Yeah, exactly. And then we're going to get some blood to send for venous, and it's going to be for
CBC.
potassium, magnesium, okay?
10-6.
Those two are the most important things right now we're going to be worrying about. Now, Caleb mentioned this, started talking about besides the H's, we got the T's.
toxicity.
Toxicity, okay, so did I get a little heavy-handed with my medications up here? Maybe so. We need to look back and make sure all my syringes are not empty, okay? Haven't done anything yet. But, so you got the word toxicity. Another T that he could be doing right now.
Tamponade.
Well, tamponade, cardiac tamponade. What is he doing that could really hurt somebody? Right ribs to get a,
Hemathorax.
there you go, okay, there's another T. Let's see, then we got some
How you doing, bro?
Thrombosis.
thrombosis of what?
You for break?
Coronary artery?
Coronary.
Yeah, keep on going, there you go, somebody's got to jump in again.
Good job.
All right. So we've got to sit there and think about what is causing his problem. We've got him back on the, well, we're fixing to. And he's still working
How
on
would
it.
we know that we've got spontaneous circulation back?
What are the things
If
he's
you've
showing
got
us?
PEA that's showing a good
He's got a nice pulse up
rhythm, but you
there.
don't feel a pulse, what's another way you can tell?
He's got blood pressure coming up, okay? I'm starting to feel something. Also, my end-tidal CO2 is getting to be 30 millimeters of mercury. If it's going from 20 to 30, that means not only is it good compressions, he's starting to get a spontaneous return of circulation. So we consider him back off for just a second, and Carol check a pulse.
Okay? So we're not doing compressions. Do we have a pulse? We got a
It
pulse.
matches. All right. So now,
So now we're talking about what do we do once he's got his pulse back? So we're
Yeah,
talking
what
about initiating the transfer, taking care of him, keeping him stabilized until the EMT show up, right? So return to spontaneous circulation, you want to keep, if the patient's not conscious, you want to make sure that you're keeping the patient with the hypothermia to reduce or to maintain neurological function. It slows down the metabolism and helps with that. If the head doesn't
No, sorry.
So, in the OR, we don't have a problem with keeping a patient cold.
No, not at all.
So we would just make sure that we put ice bags under the armpits and at the thighs to keep them cold. We don't have hypothermia blankets in our crash cart, do we? No.
Is
So
that for MH?
that can be for MH, but it's the same concept. You're keeping the patient
Now,
cold.
there's some
To
question
protect, to protect brain
up here, brain function, okay? 'Cause you see those guys that get hit on the football field?
Yeah, they're packing the ice.
They're putting, packing them ice and
Ice.
sending them over to Presby or Baylor, whatever it may be.
Okay.
So that'd be one thing to do. Now, she talked about, we're all sitting there and go, okay, guys doing great, what are we gonna do now? I'm going back to get lunch. No, this guy needs to go somewhere. Where's he going? Transfer.
He's got-
And so, who the transfer, who do we call? 911, we've got
Is this
a.
systemic? Dr. Burke, is this systemic?
It's systemic, okay, so it is.
I'm gonna call the transfer number. RN number, you call number, they call 911.
Right?
Right on.
Okay?
Okay, so I'm gonna give report, we're gonna get a 12 lead. I'm gonna call the report.
If we haven't already done labs, we're gonna
Right,
do
we're
labs.
gonna labs,
We're gonna fax over the EKG.
EKG, all that stuff that was going on while we were doing this.
Okay. And so RN to RN, doctor to
RN
doctor,
to doctor.
to tell
So,
us to pick up the patient.
Which
here.
RN needs to be giving the report?
The circulator,
Circulator.
Yes, why?
because this is
I
our
interview
room.
the patient, I'm a.
You know what happened with the patient,
You
so
were
it's real
here.
important that if that's your patient, you're the one giving the report. If PACU were to come over here, they just came over to help. They don't
Right
know
on.
what's going on with that patient, so that's real important. And you stay with that patient until that patient leaves in an ambulance. That is your patient. It doesn't matter if you have another case to follow, that's not important. You're making sure that that patient is okay and makes it over to Presby. So your charge nurse is gonna take care of that next case for you, if need be. You're gonna stay with your patient.
Phyllis, you got my next case?
I have a question. That day Dr. Suresh went with the patient. Is that usual?
It can be, I'd
Okay.
go. If it was my
Okay.
patient, I'd get in the box and
That's
ride.
what he did.
Yeah, that's
And
exactly
then,
right.
Yeah.
the vascular surgeon went and talked to the family at that point.
Yeah.
And there's different forms, you have to make sure you have your paperwork, but there's no stress. The only thing that has to go right then when EMT arrives is a copy of the H&P, doctor's consent to transfer, and then the patient's family has to sign that too. Any lab work, copy of the EKG, anything you have, send. You can always fax in the rest of your information to that fax number that's on the algorithm. So it's better to do the paperwork properly and have as much information and have it accurate, because that is a part of their chart. So if anything were to happen and that case went to court, that paperwork has your name on it. So make sure it's done correctly and as accurate as possible, okay?
The other thing is that there are egos involved everywhere, especially to make you feel some guilt on somebody's part, like my part up here taking care of this patient, what have I done wrong? And so I may not be thinking quite as straight. That's the beauty of having this cognitive aid in here. Okay, I'm calling out the drugs and I make a mistake, I forget one. Or I go to a different page in my mind, I should be going with this. Don't hesitate to say, maybe we should think about so-and-so. And put everybody back on the right track so we're all thinking the same thing. So it doesn't hurt to say, hey, I think we need to change. I think maybe that wasn't the right idea.
Like that date, Sarah Burke said,
Yeah.
you're at your max dose of adenosine.
Yeah, Max does
And she
Denison,
said it twice and clearly, so it was
and
great.
at that point in time, when SVT is AFib. So now it's time to control the rate with a beta block or a calcium channel block. So you got to be able. So you have to know what the parameters are, and don't hesitate to say, you know what? Hate to hurt your feelings, but maybe not.
Don't be intimidated.
Yeah, don't be intimidated.
Your obligation is for the safety of the
You can just
patient,
tweet this
not
right
of their
now.
ego.
And while we're sitting there, this is fairly quiet and easy going on now, but
Yeah.
in the whole, when the thing's really happening, it's going fast.
Yeah.
It's good to have somebody who's on the sidelines just playing armchair quarterback and making sure things are done right. Don't forget anything.
Proper medication being documented.
Yeah, our document on that.
Right now.
Yeah,
Usually who's the
exactly.
recording,
Recording
who's the
nurse.
one recording.
Yeah.
You have to look at those.
Any questions?
Thank you, Dr. Burke.
No, thank y'all for waiting so long.
Thank
I
We
know it's-
appreciate it.
Well, it's 20 minutes.
Oh, he gave us a chance to go over the paperwork
Yeah.
and talk about
Yeah,
scenarios.
yeah.
It was good. Thank you.